So it gives me great delight to see so many people in the audience and really, really looking forward to a wonderful afternoon. I'm grateful also for a chance to have a couple of minutes on the podium here to give some thanks to you all. And first, of course, I'd like to thank UCL and the team of soldiers who helped make this event planning possible and also give us this wonderful venue. And I give my thanks to you all on behalf of the Lancet. Our editor-in-chief, Richard Horton, is here. I'm very pleased about that, as I know you are, and he's going to provide some closing remarks. My colleague, Sabine Kleinart, is here. Our head of media and communications, who did a sensational job helping us plan for the dissemination of this series, is here. And Danielle Gash, the assistant editor, who really whipped these already wonderful papers into shape. And really, by virtue of that, you'll see that you really, really have inspired us. We're extremely proud of this series. In addition to the two series papers that were generated that are outstanding, we also commissioned 2 excellent commentaries, 2 pieces in our perspective section. We chose one of our editorial slots this week to highlight the series, and if that weren't enough, you ended up on the front cover of this week's journal. And in case you were wondering, that's not normal for a series. That is exceptional. And that's a great credit to you, Richard, and to your colleagues for the excellence of your work, the urgency of the mission that you're on, and our great fortune to be able to partner with you to bring visibility to what we now understand to be a neglected health issue. I really want to be able to say a huge thanks to Richard Watt. I've enjoyed, Richard, working with you so much on this project. You've been an incredible leader. And when I think back about how your name came to my attention, it's a funny story that I think people will appreciate. We were in a commissioning meeting at the Lancet only really about a year ago, and one of our colleagues, Stephanie Clegg, who's on our communications team, said, "Oh, I heard this wonderful speaker at UCL a few years ago," but he stuck in her mind, and she said, "Why don't you reach out to Richard Watt?" And all I did was sort of cold email you, and within a week we were on the phone together. Within 2 weeks you had 2 outstanding paper outlines, which we were very excited about. I only had to ask you once to consider diversity on your author team. You came up with a sensational international team of authors that span geography and gender and expertise, and we're just so thrilled and grateful. I really genuinely have learned so much about this field through this series. For those other authors who have traveled to come here, we're very grateful, and we look forward to meeting you and hearing you speak this afternoon. And all the other speakers and stakeholders that have come to join us today to discuss the issues that this series raises. We're very grateful. Really, really looking forward to a stimulating afternoon. So I hope everyone enjoys the event.
Thank you very much, Jocelyn, for that very, very kind introduction. So for those of you who don't know me, I'm Richard Watt. I'm the Professor in Dental Public Health here at UCL. And it is my great pleasure, it is my great pride and excitement to welcome you here to UCL for this very special event. Many of us in this room from an oral health background realise perhaps the global importance of oral diseases, but to translate that message to our broader audience is a major step forward. And to feature in the Lancet so heavily is such an exciting opportunity for all of us. In the audience here, I'm delighted that we have a very distinguished and varied audience of people from different backgrounds, but very importantly, we have people from all over the world. From my reckoning, we have people from Japan, from Brazil, from New Zealand, from Australia, from the US, from Canada, from many different European countries, and even from Boris's Britain, we have some representation as well. So we've got an exciting agenda this afternoon. We've carefully planned this event to try and cover the topics in the series. So we've got presentations, short presentations from 4 of the co-authors. And then, very importantly, we have an expert panel, stakeholder panel, that will consider the implications, the topics raised in our papers, and have a general debate and discussion. And at the end of the afternoon, we have a lot of time for you as the audience to ask questions, engage with us, to really raise the agenda and question, debate this topic. One of the challenges of this afternoon is to try and keep to time. So we've got some very skilled facilitators. Lorna McPherson and Paul Allison are going to be chairing the sessions to try and make sure we keep to time to really ensure that things run as smoothly as possible. You may have noticed that we're filming this event because we have a global interest in our topic, and not everyone can be here today for obvious reasons. So we're filming this event, and then once the event's finished, we will place the filmed summary on the different websites from the different organisations that we're from. What I'd like to briefly do, and Jocelyn has said a couple of words on this, but just to give a little bit of background to where we are this afternoon. So as Jocelyn has just mentioned, it was actually the 18th of January 2018 that Jocelyn Clark emailed me to inquire about my interest in a potential oral health series. Well, I don't know about you, but you don't often get an email from the Lancet. And at first, I sort of thought, is this true? I sort of thought, was one of my friends sort of, is this a hoax? Are they trying to tease me into believing something that wasn't quite possible? But no, it was Jocelyn, it was real. And 18 months later, here we are with the final product that you can see in your packs and in the papers that are now published and associated outputs. So it's been an incredible process, and I think all of us as co-authors have learned a great deal from this process, and it really has been an exciting journey, truly has been exciting, and really exciting opportunity for us in the oral health community. What I'd like to now do is just to highlight our co-authors and to emphasize the mix of geographical spread, gender balance, and expertise. So we have Roger from Porto Alegre in the south of Brazil. We have Carol from Bogota in Colombia. We have Kristen from San Francisco on the west coast of the US. We have Bob from Pittsburgh in the middle of the US. We have Habib from New York in terms of New York University. We have Paul from Montreal in Canada. We have Blanid from Dublin in Ireland. We have Lorna from Glasgow in Scotland. We have Renato, myself, from UCL in London. And then we have Stefan from Heidelberg in the Netherlands/Germany. And also Manu from Delhi. And last, we have Marco Perez from the Gold Coast in Australia. So we really do have a very wide and diverse range of authors from different countries and different backgrounds. And I would like to thank all the authors for their work collectively, because we have been a very, very good team that have worked collectively to achieve this. And I would like to acknowledge and thank all of you for your expertise and support. Thank you. And here it is. So as Jocelyn said, for the front cover to feature us, I was almost bowled over. So it is with huge excitement and pride that we present the Lancet series that's just been published. I think what might be quite important just to summarize for those not familiar with Lancet series is a Lancet series is really a blend and synthesis of a topic that is looking at a critical review of the subject, a commentary, and indeed data analysis and presentation of relevant background data. The primary aim of our papers was really to provide an introduction and overview of oral health to a broader audience, to a broader medical, global health and policy audience that the Lancet clearly reaches out to. These papers are very much focusing on a global perspective, both high-income, middle-income and low-income countries. We're trying to capture the essence across the globe. It is impossible in these two papers to cover in depth the whole range of our topic areas. So we had to be very selective to copy and look and focus on particular topics. We couldn't cover the great deal of everything. But essentially what our key messages are, what we'll hear in the next few minutes, is the global health importance of oral diseases in terms of prevalence, impact and burden, the importance of understanding the inequalities in oral diseases both within and across countries, and very much of importance is addressing the social and commercial determinants of oral diseases, particularly in relation to sugar and particularly linking to the broader NCD agenda. And then lastly, to understand the limitations of our dental care systems and the need for reform and change in oral health systems to combat this global problem. So that's what we've tried to achieve in these papers. We've been delighted with the press interest and coverage. There's been significant interest from all around the world, India, US, Germany, etc. Really substantial interest. Some of my colleagues, when they've read the papers, said they made them emotional and start crying. Now, I was concerned, did that mean they were worried it was so badly written? But no, I think they felt quite inspired by what we managed to do. So what I'd like to just finish off by doing is thanking Jocelyn, because Jocelyn really has been an enormous support to us as a group of authors. She's supported us, given us guidance, and really has been an enthusiastic supporter from the very beginning. So thank you, Jocelyn. But I would like to thank Danielle, Anne, and Stephanie, because they, members of the wider Lancet team, have been so supportive and given us support and guidance throughout. I would also like to thank the reviewers of the papers, because both the papers were reviewed by multiple reviewers and gave very useful comments and guide. Finally, I would like to thank a special person who is not here today. The late Professor Aubrey Shyam inspired me and many of the co-authors, and I think today he would be immensely proud of what we've achieved this afternoon and with the papers. So that is the introduction from Jocelyn and myself. What we're now going to do is ask Professor Lorna McPherson to come up to introduce the speakers. Lorna is a Professor of Dental Public Health at the University of Glasgow and one of the co-authors in the series. So over to you.
Thank you very much, Richard, for that introduction, and also very many thanks to you and to the Lancet team for giving many of us the opportunity to contribute to this series on oral health. So as you've heard, I've been asked to chair the first session of the programme, in which a number of the series authors will be presenting the key messages and discussion points outlined in the Lancet series. So first of all, we'll be looking at the public health challenges associated with oral diseases across the globe, highlight the limitations of current approaches and healthcare systems related to oral health care and the prevention of disease, and then go on to present what we're calling our call for action. So here we'll outline the need for new approaches and new ways of thinking to tackle the problems, with key policy recommendations being proposed within the wider global policy agendas. So as you've heard from Richard, there'll be four short, rapid presentations, and so each speaker will just follow on from the other. There won't be questions at this point, but there will be opportunities later on in the afternoon for plenty of questions and discussion. So I'm very pleased, therefore, to welcome our first speaker, who is Marco Perez from Griffith University in Queensland, Australia, and he will be outlining the global public health importance of oral diseases. Marco.
Thank you for coming. I would like to thank the Lancet editorial team, particularly Dr. Jocelyn Clark and Professor Richard Watt, for this opportunity to be here today. It's an enormous pleasure and honor. My task this afternoon is to give a brief overview of the global public health importance of oral disease. Oral disease include a range of chronic clinical conditions that affect the teeth and mouth, including dental caries, periodontal disease, and oral cancer, along with tooth loss, which is not a disease, but a consequence of dental diseases. The most common oral conditions fulfill all criteria to be considered as public health problems. Despite being largely preventable, oral diseases are highly prevalent throughout the life course and have substantial adverse effects on individuals, communities, and the wider society. Oral disease are global public health problems with particular concern over the rising prevalence in many low and middle income countries linked to wider social, economic, and commercial changes. Untreated dental caries in permanent teeth is the most prevalent conditions among all conditions investigated in the global burden of diseases studies, affecting almost 2.5 billion people worldwide. The global age standardized prevalence and incidence of untreated caries remained stable between 1990 and 2010. There is evidence that the burden of untreated caries is shifting from children to adults, with 3 peaks in prevalence at ages of 6, 25, and 70 years. Severe periodontitis is the 6th most prevalent condition in the world. Between 1990 and 2010, the global age standardized prevalence of severe periodontitis was static at nearly 11%. Prevalence increased gradually with age, showing a steep increase between the 3rd and 4th decades of life that was driven by a peak in incidence at around 30 years of life. Untreated dental caries in decidual teeth was the 10th most prevalent condition, affecting 9% of the global child population between 1990 and 2010 and 7.8% in 2015. Between 1990 and 2010, the global age standardized prevalence of edentate people, those with complete tooth loss, decreased from 4.4% to 2.2%. Complete tooth loss affects 158 million people worldwide. Prevalence increased gradually with age, showing a steep increase around the 7th decade of life that was associated with a peak of incidence at 65 years. Geographic difference in prevalence, incidence, and rate of improvement from 1990 and 2010 were stark. Severe tooth loss, which is defined by having fewer than 9 remaining permanent teeth, shows a significant decline in its prevalence and incidence between 1990 and 2010 at the global, regional, and country levels. The age standardized prevalence reduced from 4.4 in 1990 to 2.4 in 2010. Lips and oral cavity cancers are among the top 50 most common cancers worldwide, with over 500,000 incident cases in 2018. The total number of deaths due to cancer of lips and oral cavity in 2018 was over 107,000, of which 67% in males, an age standardized rate of 2.8 per 100,000 males and 1.2 per 100,000 females. Data from 2018 showed that oral cancer has the highest incidence among all cancers in Melanesia and South Asia among males, and is the leading cause of cancer-related mortality among males in India and Sri Lanka. Furthermore, among males living in countries with a low and medium human development index, the age standardized rate of oral cancer is the 4th highest of all cancers, accounts for 8.7 per 100,000 males. So in total, 3.5 billion people affected by oral conditions globally. Oral conditions disproportionately affect impoverished and social disadvantaged members of society. A strong and consistent social gradient exists between socioeconomic status and the prevalence and severity of oral disease. Oral disease can be considered as a sensitive marker of social disadvantage, being an early indicator of population ill health linked to deprivation. Oral disease and oral health inequalities are directly influenced by wider social and commercial determinants, which are the underlying drivers of poor population oral health. There is a consistent body of evidence linking socioeconomic position and oral health. A 2015 systematic review assessed the association between socioeconomic position and caries experience, and in 155 studies involved a total of over 300,000 people. The association between low educational background and having experienced caries was significantly higher in countries with high Human Development Index scores relative to countries with low index scores, even after adjusting for potential confounders. Lower socioeconomic position was also significant association with having untreated caries lesions of any caries experience. These findings were confirmed by an updated systematic review performed in 2018. Another systematic review showed that disadvantaged socioeconomic circumstances were associated with poor periodontal health even after controlling for smoking. Association between low socioeconomic status and oral cancer was found in both low-middle-income countries and high-income countries, even adjustment for behavioral confounders. Studies of socioeconomic inequalities in dental disease over the life course of individuals are rare and have mostly focused on population-based birth cohorts from Dunedin in New Zealand and Pelotas in Brazil. Findings from these birth cohort studies show that untreated dental caries and periodontal disease in adulthood were negatively associated with childhood socioeconomic conditions. Homeless, refugees, indigenous, disabled, prisoners have more untreated dental caries, tooth loss, toothache than the general population, which serves as a classic example of cleavage edge of inequalities, as you can see in this figure. Oral disease affects individuals, families, and society. Dental disease imposes a substantial burden in society. Their economic burden encompasses direct costs such as treatment expenditures, but also indirect costs such as productivity loss due to absence from work and school, and intangible costs, for example, pain, problems with biting, chewing and eating, tasting, speaking, and the expression of smiling. Lost time from school and adverse effect of school performance due to oral conditions have been identified in several studies from different parts of the world. General anesthesia, due to dental reasons, is the second most important cause for hospitalization among children in Australia. In Canada, dental-related issues resulted in an average of 3.5 hours of lost working time per person per year, costing 4 million lost work hours, a productivity loss of over 1 billion Canadian dollars. In Australia, 9% of employed people missed one or more half days in a year due to dental problems, with lost productivity costs of 606 million Australian dollars. In Brazil, a nationwide study showed that orofacial pain leads to 50% absent from work in the 6 months before the survey. So, worldwide, in 2015, dental disease account for 357 billion American dollars in direct costs and 188 billion American dollars in indirect costs. In the 28 European Union member states, in 2015, dental disease costs were 90 billion euros, ranking 30 behind diabetes and cardiovascular disease. So in summary, as you can see, oral health really matters. Thank you very much.
My role today is to talk about the social and commercial determinants of oral diseases. And I want to start with this figure, which represents the WHO conceptual framework for action on the social determinants of health. It highlights how structural determinants, such as economic, social, and welfare policies, can generate social hierarchies and influence the socioeconomic status of individuals within societies. Socioeconomic status can then influence health through the circumstances in which people live, work, and age, and their risks for disease. These intermediate determinants include housing and working conditions, social capital, psychosocial factors such as stress and social support, and access to good quality health care. At the most proximal point in the model, behaviors and biological processes mediate the health effects of social determinants. Oral diseases and inequalities in oral health are caused by a complex array of individual social, environmental, economic, and political determinants, mostly shared with other NCDs. Increasingly, some in the public health community have argued that equal concern now needs to be focused on the commercial determinants of health, which we've added to the model here. Commercial determinants of health have been defined as strategies and approaches used by the private sector to promote products and choices that are detrimental to health. Corporate strategies include marketing that aims to enhance the desirability and acceptability of products, lobbying to influence public health policy and legislation, using corporate responsibility strategies to enhance acceptability of producers through sponsorship of sporting events and healthcare initiatives, and through globally extended supply chains. Particularly relevant to the commercial determinants of oral health is the case of the global sugar industry. Worldwide, we've seen a steady overall increase in sugar production sourced from cane and beet sugar, which is the most widely available sweetener. As a consequence, in many low and middle income countries, the prevalence of dental caries is increasing at the same time as reported marked increases in the consumption of sugars, including sugary drinks. Economic development in many low and middle income countries has moved millions out of poverty, resulting in rapid demographic and nutritional transition characterized by adverse changes in the diet, physical activity, and health. Multinational corporations are expanding their reach from near-saturated markets in high-income countries to target new opportunities in emerging markets. For example, Coca-Cola has outlined plans to invest more than $12 billion US on marketing across Africa by 2020. PepsiCo has set aside $12 billion for its Indian operations to take place by 2020. In contrast, the World Health Organization's budget for 2017 was a mere $4.4 billion. This slide offers several examples of the global sugar industry in action. The international soft drinks market, for example, is dominated by Coca-Cola and PepsiCo. These two companies alone account for over a third of worldwide soft drink sales, with accumulated revenues in excess of $100 billion US, which exceeds the gross domestic products of even high-income countries. In 2013, beverage companies spent $866 million on advertising sugary drinks in the US alone. $83 million was spent marketing sugary drinks on Spanish language TV in 2014, which was a 44% increase from 2010. In 2003, when the cane and beet sugar industry was unhappy with an expert WHO report recommending a quantitative limit on free sugars consumption, they worked through 2 US senators to threaten the WHO with getting $406 million of US funding withdrawn. This was one prong and a multi-pronged effort that ultimately contributed to the quantitative limit being omitted from the WHO's 2004 Global Strategy in Diet and Physical Activity. And between 2009 and 2015, Coca-Cola, PepsiCo, and the American Beverage Association spent $114 million on federal lobbying to oppose a US-wide sugary beverage tax. Other relevant industry tactics include discrediting major research and recommendations on diet and nutrition, and funding ostensibly independent organizations to obtain access to key decision makers and legitimize statements downplaying the role of sugars in the etiology of disease. Another important commercial determinant is commercial baby foods, which are generally highly processed products with a high sugar content. A 2018 European Commission report, which analyzed over 4,200 commercial baby foods and drinks sold across Europe, revealed that 41% of products contain free sugars, which were particularly abundant in baby biscuits, cereals, juices and drinks, fruit products, desserts, yogurts, and other snacks. This is a major concern because consumption of sweetened commercial baby foods during the earliest years of life is a risk for early childhood caries. It may encourage infants to develop a preference for sweetness, and it might contribute to overweight later in childhood. In 2010, the global commercial baby foods market was estimated to be worth over $37 billion. Europe, USA, and Asia hold the major share of the market. However, emerging economies are expected to see high growth rates. This chart represents an analysis of sales data in selected countries and shows high growth in sales between 2004 and 2017, particularly in China, the United Arab Emirates, Russia, Vietnam, Peru, and Indonesia. It also shows that sales have risen steadily in the Czech Republic, Colombia, Brazil, and South Africa. In summary, we argue that together with other international health frameworks, the commercial determinants agenda provides opportunities for effective advocacy, benefiting not only oral health, but also NCDs and sustainable development at large. For example, the dental profession has an important role to play in supporting the implementation of the WHO guidelines to reduce free sugars consumption. This will require a wide array of upstream actions that directly challenge the sugary food and beverage industry. And these efforts will benefit from partnerships across the NCD community. However, I have one final note. In an accompanying comment to the series, Lisa Barrow and I call attention to some troubling financial relationships between dental research organizations and major global confectionery, chocolate, chewing gum, ice cream, sugary snack, and drinks companies. These include Unilever, Mars Wrigley, Cloetta, and Mondelez. Based on industry interference with tobacco, obesity, and dental caries research, we argue that it's important to consider the potential influence of these organizations on directing our profession's focus away from sugar in the past decades towards dental caries interventions with commercial applications such as xylitol products, sugar-free gum, and toothbrushing with fluoridated toothpaste, all products that these companies also happen to sell. We argue that to produce meaningful research on sugar reduction, dental organizations must address their financial conflicts of interest with the sugary food and beverage industry, and we provide guidance based on the 2009 Institute of Medicine report on conflicts of interest on how to do this. Thank you very much for your attention.
So the failure of dentistry to reduce oral health inequalities is actually not the failure of individual clinicians who are trying to do their best for their patients, but rather it's the failure of a system with an outdated philosophy underpinning it. I'm a practicing dentist. I work in the real world with wet fingers. And I provide dental care for people with disabilities and people living in marginalised groups such as homeless people and prisoners. And I get to see the consequences of poor oral health every day. Dentistry is clearly failing my patients. And indeed, it is recognised across the dental profession that we are failing patients. Ian Mills, who's the Dean of the Faculty of General Dental Practice here, noted very recently that in terms of addressing inequality in vulnerable groups, we've been largely ineffectual for most of those who are most in need of our support. Now, the current approach within dentistry is clearly not working. And in an effort to identify what needs to change, we undertook a critique of dentistry for the Oral Health series and attempted to identify some key limitations which we felt would be important to address very quickly in order to address the failures of dentistry. In this short talk, I'm not going to be able to cover everything, but I would like to highlight 4 things: the treatment focus, the payment systems that perpetuate that treatment focus, the big gap between oral health and general health, the so-called dental silo, and of course problems with service distribution. So if I come on to the treatment focus, much of dentistry is a treatment-focused, interventionist and technical philosophy. And that treatment ethos we can trace right back to 80 years ago to understandings of dental disease that were prevalent at that time. To use dental caries as an example, disease management was about early detection and then drilling and filling based on an outdated understanding that caries inevitably progressed, and in order to stop it you had to cut it out at source. And that meant literally cutting the tooth. The decision to put the drill on the tooth is crucial, because once the tooth enters that restorative cycle, it means that the restoration may break down over time in function. It has to be replaced. More invasive dentistry occurs, and there's constant refilling of the tooth. Eventually, in some cases, the tooth will fail and fail catastrophically, and it will have to be extracted. And then you move into the next phase of high-tech dentistry, which is replacing that tooth gap with a denture, a bridge, or an implant. But it doesn't have to be like this, because dental caries can be prevented and also arrested with really good evidence base for minimally intervention techniques. Allied with good individual prevention about good oral hygiene, reducing sugar consumption, and optimal exposure to fluoride. So you don't have to rush to treat dental decay with the dental drill, but many of us still do, and the drive to intervene rather than prevent is very strong. This example also highlights another area and limitation of dentistry, which is that despite the best efforts of the dental research community, there is still a scarcity of good evidence underpinning many of our procedures and interventions. And why does this happen? Well, men and women go to dental school to learn to be dentists, and learning the dental techniques is fundamental to do that. It's very difficult in a crowded curriculum to try and find time for prevention, and what sometimes our clinical restorative friends might talk about as the soft skills of communication and helping people to change their behavior. So we in dental schools, and I work in a dental school, have to face up to the fact that we may be developing clinicians and the wider dental team who are more about being treatment-centred rather than health-centred. And of course, the payment system perpetuates that treatment focus. There are many different ways of remunerating dentists, and we know how they're remunerated affects their practice. Fee per item is probably one of the dominant methods, and in that system you get paid if you treat, i.e. lift the drill, but perversely you don't get paid if you don't treat and maybe sit back and prevent, which we know, according to the evidence base, is what we need to be doing now, watching and waiting. The next thing I'd like to talk about is the artificial gap between oral and healthcare. oral health care delivery tends to have evolved completely separately from general health care, and dentists are usually trained completely separately from their doctors and nursing colleagues and the wider healthcare team. So it's perhaps not surprising that there's no tradition of working together holistically on health problems. Dentistry tends to operate within a silo, focusing perhaps very downstream on the mouth rather than looking outwards. Now, if we look at the clinical approach to prevention, this illustrates one of the problems here. Inherent in that approach is downstream work, focusing on individual behaviours with little consideration of how those behaviours are shaped and developed. And it's probably not surprising, therefore, that many of those interventions have been unsuccessful or have failed to produce effects that are sustainable. And that's probably because of that very narrow focus. We know that the causes of many non-communicable diseases are upstream and actually share common risk factors with oral disease. So it's far more pragmatic for us to get out of our dental silo and work upstream and work on the common risk factors, so reducing the risk burden for non-communicable diseases and oral diseases. We have argued in our Lancet series that the mouth and the teeth are integral to the body. So it's really important when we're moving forward to promote health that we should put the body at the mouth back into the body and use that general focus. And that challenge is for us dentistry, but I would suggest the challenge is actually for wider health. Dentists know the mouth is important. We have to convince the healthcare community that the mouth is important. My last point is relating to the mismatch between oral health needs of communities and the availability, the location, the type of dental service we provide. Oral health services are often poorly planned and based on entrepreneurial choices, that is, where the dentist wants to set up his or her practice. And so they're often poorly aligned with the needs in the local population. This means in high-income countries, young people, low-income families, indigenous people, homeless people, people living with disabilities are often underserved, while those in wealthier rural areas, urban areas, are probably overserved and perhaps sometimes overtreated. The classic Tudor Hart law. In sub-Saharan Africa and in low-income countries, the situation is far worse, with dental services often located in urban areas which are inaccessible to the rural poor, which means that people have to travel long distances to get dental care. And if that's not available, they may have to resort to traditional providers with all the problems associated with unregulated practice. Unlike medicine, in dentistry we have not used the skills and competencies of the wider dental team and other healthcare professionals. There's a range of complexity of work within dentistry, and not all of it needs a fully qualified dentist to undertake that. In many high, middle and low income settings, we would be able to increase the reach and coverage of the population if we trained a workforce with a range of appropriate skills responsive to local needs at all levels of essential, primary, secondary and tertiary care. Professor Perez has shown that oral diseases are a major global public health problem affecting over 3.5 million people, with the poor and the vulnerable experiencing the cliff edge of that extreme inequality and inaccessible services. The current system is not working and does not meet the oral health needs of large segments of the global population. It is inappropriate and unaffordable in many low-income settings. In our series, we conclude that a different and a more radical approach is now needed. Thank you.
Good afternoon, ladies and gentlemen. Let me start this brief talk on a personal note. Those who are outside of the oral health field may have difficulty understanding how important and how much it means to be here today at this point in time for the launch of the Lancet Series on oral health. And I think those here in the room, they represent the broader global oral health community at large, those who have worked in oral health internationally on various different ways. So I think we are all here to celebrate this big global community on their behalf. Trying to summarize the key policy recommendations of the series in 5 slides and 8 minutes, and capturing the complexity and the multitude of dimensions, the scenarios in different countries, is basically impossible. So please bear with me if I simplify and if I make some statements that are perhaps too general for some of your liking. We were facing similar challenges when we were putting together the content for the series, as Richard and all the other co-authors have already pointed out. I have tried to summarize the policy recommendations in 5 key areas. Let me start with the first one. The basics for sound and informed decision-making is to have solid information. And in oral health, we have been struggling for long to have up-to-date epidemiologic basic data that is comparable on the same level with other health conditions. The global burden of disease studies, as Marco pointed out, have helped in this situation a little bit, but still the oral health sector is lagging behind in many ways behind our medical and general health colleagues, particularly with regard to integration in general surveillance system at the national country level. We have very few solid evaluations of services. We have very little implementation research, particularly from low and middle income countries where the need is the greatest. And when it comes to economic evaluations, the situation is even worse. So it's no wonder that in many situations, the policy decisions are not based on evidence or on solid data. And where there is evidence, we are facing still a significant gap between the evidence and the implementation. So we have this translation issue. The second recommendation builds on the talk from Christine about the determinants of health. And of course, Lancet said that the focus of current dentistry is mainly on treatment, clinical approaches, and we are falling short of policies that address upstream determinants of oral health, and particularly commercial determinants. And that is, although we know that things like health taxes work, and that they have a beneficial impact on health, both on the NCD side, but also on oral health. And sometimes it's just the simple things that implementing would not cost very much. For example, healthy settings in schools and workplaces, to ban tobacco products, sugary drinks, unhealthy food from those places, and replacing them with more healthy options will go a long way. It doesn't cost very much in establishing such policies. In the papers, we also recommend that availability, quality, and affordability of fluorides and fluoride toothpaste needs to be strengthened, just because fluoride toothpaste is a cornerstone of self-help and the first level of preventing tooth decay, and there's very good evidence for that. But if you happen to have an oral problem, and as we heard from Marco, it is very common, you need to find a provider, a healthcare worker that can help you. And if you live in a country like Ethiopia, Somalia, where you have 1 dentist per 1 million people or less, you are stuck. What is your solution? You take a painkiller and then you go with your situation. The good thing is that toothache comes and goes, so you always have phases when you are feeling better, but it will come back. So we argue that it is necessary for full integration of oral health care that a skilled and appropriately trained healthcare worker is able to take care of the problem at every level in a primary healthcare system. And there are concepts and experience on how this can be achieved, and I won't go into any further detail because that would really overwhelm this session here. But it is clear that this shift in thinking and in integration requires shift away from the dentist-centered model. We need care delivery that is part of a team. We need a different type of workforce, and I'll get to that in a moment. Without this shift, it will not be possible to reach those 3.5 billion people that Marco mentioned, because a large majority of them has never seen a dentist in their life and will never see a dentist if we do not provide a level of care that is appropriate for those contexts. So universal access that includes oral health care under the current model is not possible. It's just not realistic. And if we don't change anything, the inequalities in and between populations will just continue to grow. So this change of focus in training a workforce is not an easy thing to do. And there are different initiatives worldwide that have already been trying to work towards a team-based approach where the role of the dentist is redefined and where the team members have flexible tasks and roles and competencies depending on the community needs, on the resources available in the respective setting, and other national and local determinants. In addition to this team approach, we are calling in general on a much bolder focus on prevention, because we are in this fortunate situation that most of the oral diseases can be largely prevented. That is not the case for many other conditions. So we need to use this and we need to make the most out of it. And we consider oral health to be part of the basic human right for health. And that means oral health, or good oral health, is a public good. And the concept of public goods means that there is a responsibility for the government and public sector to take care, to promote, to enhance this public good. And that means allocating resources, establishing systems that promote oral health as part of the entire healthcare system. How do we get there? Well, that's part of our session today, and I'm sure in the discussions that will follow, we'll talk a lot about global advocacy. So we have a lot of opportunities where we can integrate, where we can use our knowledge and our expertise and evidence and examples and case studies and situations like this Lancet series to bring oral health onto global agendas. So we have, for example, the NCDs, and we'll talk a lot about the chronic disease movement today, primary health care, universal health coverage, of course the SDGs, those are the big ones. There's also another opportunity that is often overlooked and not so prominently discussed in circles that are outside of oral health, is the Minamata Convention on the elimination of mercury. It's relevant for oral health because one of the most commonly used filling materials, dental amalgam, contains mercury, and the convention has provisions to phase down amalgam. But the convention also has provisions for prevention and promotion of oral health, which are often overlooked and could be leveraged in a very different way for advocating for oral health. For all of this, we need alignment with regard to problem definition. We have in the oral health community a very fragmented set of stakeholders. The landscape is broad to some extent, and each of these stakeholders has different interests and a different constituency. And they all see different focus areas or different priorities. How can we get together and center around one common cause? And how can we then move on towards solutions? It's a complicated and complex process that requires leadership, motivation, persistence, and direction. Let me take this opportunity to remember another pioneer in global oral health and leadership, the late Professor Martin Hopdell, who worked very closely with Aubrey Shame that Richard already recognized at the beginning. This Lancet Oral Health series would have been very much to his liking. The series, as I said, is also recognition for everyone here in the room, and for the global community at large, for all those who advocate for oral health in different contexts. It's been a long way to get to this point, and it's definitely a moment to celebrate and to cherish, and to be happy about. And I want to thank the Lancet and the entire team, my fellow co-authors, and all the involved universities. But I think the real work has only just started. We need to seize this window of opportunity to make a real change to the state of oral health worldwide, because we want to make an impact on the disease burden, which has not happened so far, despite massive investments from health systems around the world. We want to tackle the disease burden through evolving healthcare systems and by fighting the commercial determinants. Ladies and gentlemen, we have been waiting long for an opportunity like this, and let there be no doubt, we are ready to speak up and to act. Thank you.
Thanks very much, Habib, for your presentation, which very much set out potential action points and recommendations for the future. And I'd also now just like to very much thank all the speakers from the first part of this afternoon, and particularly for keeping so well to time. I know that's been a real challenge, just giving you 5 slides in which to cover, very complex areas. So thanks again for managing to do that. So these short author presentations have very much provided an excellent overview of the key themes within our Lancet series. And I'm now delighted to introduce Paul Allison from McGill University, who's now going to chair the second part of this afternoon, which will involve a stakeholder panel of invited experts. So, Paul.
And thank you very much to, I'd really like to say a really big thank you, particularly to Richard for your leadership in corralling us all together to get this done, and also again to Jocelyn and the whole Lancet team for setting up this event, and of course for the whole work involved with the papers. It's a real honor and privilege to have been involved. As Lorna just mentioned, the goal of this particular session is to give the opportunity to representatives of a number of different organizations to respond and react to the papers that we've just recently read, and the summaries that we've just been given. They've been given, just like the presenters were given, they've been given 8 minutes. They don't have slides, so they've got a short period of time, and I will be keeping everyone to that short period of time. And I would ask you all to hold your questions, keep your questions, write down your questions until the end, at which point we'll be able to have a discussion with everybody getting involved. Hopefully we can have a great discussion at the end. So I'm not going to give a big long introduction to each of the speakers, because you have a more fulsome presentation of their backgrounds in the program. So it'll just be a very quick presentation or introduction to each of the speakers. And so without further ado, I'm going to ask the first speaker to come up. So that's Robert Beaglehole, and he's a public health physician from the University of Auckland. Thank you.
It's a great pleasure to be here, and of course I would like to thank you, Richard, for all that you've done, and Jocelyn for you and your team at the Lancet. When I was asked to prepare this comment, promoting radical action on global oral health, I was given 2 questions to address. Would we, please explore the reasons for the neglect of global oral health? And secondly, would we suggest a way forward? And this is what we have tried to do. By way of explanation, the first author of this comment is a practicing dentist in New Zealand and a public health advocate, he calls himself. By contrast, I am a more broadly based NCD prevention and control person, but I did realize this morning that when I was at the WHO, I was responsible for the global oral health program run by a colleague of yours, Paul Eric Peterson. That's my only claim to specialised oral public health knowledge. The first question, why the neglect? The neglect so beautifully, exquisitely, painfully demonstrated in the first paper. We can only begin to understand that neglect if we have a framework for considering how public health issues rise to the surface of global public health. The best framework we have was published, of course, in the Lancet in 2007 by Jeremy Schiffman and colleagues, and has been explored in more detail in several other papers considering a variety of global public health issues from tobacco, alcohol, maternal and child health, etc. Schiffman proposes 4 characteristics, 4 distinguishing features of an issue which needs to be addressed before it will reach the surface of the global health agenda. And they are, firstly, the ideas expressed by the advocates, the way the issue is framed, both internally and externally for the political and the public audiences, the ideas. Secondly, the features of the problem, the size of the burden, the severity of the burden of the condition we're considering. Are there interventions available? Are they cost effective? These 2 issues, the ideas expressed and the features, we summarize as the stories that are told about the issue. The third necessary prerequisite is actors, powerful, committed, resourced actors. And the fourth issue is the political context in which we are operating. If these 4 characteristics are aligned, congruent, we have a much greater chance of making progress in inserting our issue into the global health agenda. So where are we with regard to global oral health? We have wonderful stories. Preventable burden, serious issue, children, adults, and above all, Kristen, we have a villain. And we have allies that could be much more closely aligned with the prevention issue, whether that be the dental profession, as you, Professor Daly, were talking about, or indeed the FDI. So we have stories, and our contention is that the global health community is not yet telling the stories in a compelling, exciting, simple way. And that's one reason why I think global oral health is still neglected. We think the actors still need to be energized. Habib, you talked about fragmented actors, activists. There's much more that could be done to build a network of committed activists. The political context, we think, is absolutely right for making progress, particularly universal health coverage. So what is the way forward? And we've proposed 2 options. The first, more of the same. Aligning oral health with the NCD framework more generally. Under the United Nations 3-level, high-level meetings, policy recommendations. Using Habib, the common risk factor approach. Did you mention that? Sorry, Professor Daly. We would suggest that this approach has failed. Richard, you and Aubrey wrote about the common risk factor approach perhaps 2 decades ago, almost. Yet, global oral health is still neglected. So why will more of the same make a difference? Point for discussion. If you go the NCD route, you must, of course, align with the NCD Alliance, a wonderful civil society organisation, which I'm sure Nina will talk about. The agenda for the NCD Alliance has recently been increased from the 4 main NCDs, cardiovascular disease, cancer, diabetes, chronic respiratory diseases, to include air pollution, mental health, and dementia. So our question to you is how within that NCD complex will oral health rise to the surface. We think that's going to be a challenge. So we are proposing that the global oral health movement maintain its independence, and that a reinvigorated global oral health movement would have strong leadership, committed leadership, simple stories, compelling stories, and would have two key tasks. And we'd like to propose that the authors of this series, under your leadership, Richard, build a new network. And we've tentatively called it LOAN, the Lancet Oral Health Action Network. And we would propose two key tasks for this network. Firstly, leading the big sugar campaigns, leading the anti-sugar industry work. And the reason why we suggest that you people do this is that because the relationship between sugar and teeth is much clearer, more transparent than sugar and diabetes, sugar and obesity. And when the obesity and diabetes people talk about the social determinants, they barely mention oral health. I think there is scope for LOAN, whatever you call it, to take the leadership here. The other task, and building on, again, the deficiencies of the dental profession, might we say, is to focus on building an oral health workforce fit for purpose in low-income countries. Personally, I'd forget the dental profession. If you could convince 0.001% of the dentists in the world to be active, that would be a miracle. I think you need 2 or 3 committed dentists in each country to take the leadership on these issues. In summary, global oral health is a social justice issue. Your movement must be driven by values. It requires courageous and radical leadership in the context of planetary health. Ladies and gentlemen, I think the time is right. The window is right. The series is a landmark series. There is no excuse now for coming back in 5 years' time and saying global oral health is neglected. I think collectively we can make a huge difference to global oral health in the short term. Thank you.
It's a real pleasure to be here. Indeed, I'm from the NCD Alliance, which is a global network of civil society organisations. To give you a quick flavour of who we are and what we do, Robert has already alluded to it, but we are trying to lead the way to a world free of preventable NCDs. We've just hit our 10th birthday, quite a milestone. We were founded in 2009 by organisations representing the big 4 NCDs that were just referred to, and they were joined early in our existence by FDI, World Dental Federation, and these days we're a network of about 2,000 civil society organisations worldwide in 170 countries, and we've also been joined recently by IADR as well. We also have, and this is quite important for what I'm going to say in a few minutes, an alliance of 60 national and regional alliances in different countries. So this is quite a vital tool that helps us with our global advocacy work and taking it from the global to the national and the local level. And what binds us, and also what binds us with you as the oral health community, is common risk factors, powerful, very well-resourced opponents, as we've heard, woeful, absolutely pitiful underfunding of NCDs in relation to the global burden of disease and in relation to other global health priorities. And as a result of that, NCDs are often painted as a tsunami, and they're becoming, or they have become, the #1 cause of premature death and disability worldwide, and that's in all resource settings. Even in sub-Saharan Africa, NCDs are going to overtake other causes of death by 2030. And yet, the global funding situation, as I said, is absolutely pitiful. What we also have in common is common solutions. We know ways forward. We have the WHO best buys, many of which would be great for oral health as well. and recommended interventions, and we have now an approach to universal health coverage, which will be discussed at the UN General Assembly this September, and equitable access to treatment and care as a global health priority. So this is absolutely vital. What we also have in common is several myths that need busting. So we often hear NCDs are a first world problem, NCDs only affect rich people, NCDs are about aging populations, and we know, and we've seen it here today, that that's absolutely not the case. NCDs are very much a social justice issue, a development issue, an environmental issue, as Habib's just said, a gender issue, a child rights issue, a human rights issue. You know, we have a cross-cutting agenda which allows us also to team up with many other global health organizations, but many other organizations that support the Sustainable Development Goals. So I have to say, hearty congratulations from our side. We really very much appreciate the series. It makes an irrefutable case for action, more action on global health, but also a different course of action on global health, and we really appreciate that reflection. What's very, very valuable that we've been talking about here, and the evidence base is being built by many of you in this room, the investment case on oral health, which is extremely important if we want to make sure that we accelerate the case for action not only at global level, but at the national and local level as well. So oral health is very much an NCD priority. Two things that I want to pull out from the series, which are extremely valuable. The emphasis on multimorbidity and comorbidities. I think this is a space where we could have much more action, much more research, and strengthen the case even further. Oral health has links with over 100 other health conditions, both communicable and non-communicable, maternal and child health, and especially, and I'm really pleased that this is mentioned, mustn't be neglected, mental health as well. I think what I want to put to you is that a huge value and the uniqueness of the oral health community is the early warning system that you can provide. The canary in the coal mine is mentioned in the series. I would rather choose a different analogy because that one doesn't end well for the canary. Thinking of NCDs as a tsunami that's very much threatening to dash our health systems on the rocks, whether that's in developing countries that are just bringing their health systems into operation, or in countries like the UK with mature NHS. NCDs are an existential threat to our health systems. Oral health can be the lighthouse. You can position yourselves as the lighthouse. You have a unique vantage point, and you have this early warning function that can help us avert much bigger disaster on the horizon in the very near future. Child obesity, I'm sure Tim will speak about this in much more detail in a moment, but this is just one area where there's so much more that can be done. So in the series, we really particularly appreciate, I had a checklist before I started reading it of things that I wanted to hear and wanted to read. Social determinants and commercial determinants, and also some consideration of the role of international trade policies in that environment, which is extremely important. I also wanted to see a mention of baby foods and of alcohol as key risk factors, so those are boxes that have been checked as well. So often the alcohol industry's part of the, let's say, junk food industrial complex is ignored, and they're completely let off the hook, in my view, when it comes to obesity, type 2 diabetes, because it's so often seen as, well, that doesn't concern children, and we're going to focus the obesity debate on children, therefore we don't need to think about alcohol. Very, very much not the case. I was talking to a Mexican advocate about children as young as 10 being checked into rehab in Mexico. You know, it's a children's health issue as well, but in any case, alcohol and nutrition, these are part of the same coin, also very relevant for oral health, so let's go there, let's talk about this, let's not let them off the hook. I was overjoyed as well to see the emphasis on marginalised groups, indigenous peoples, prisoners, rural communities, and so on. There's obviously inconvenient truths to be talked about there, that even in the most privileged parts of the world, large groups of people are still left behind. The oral health profession sees this before. Again, you can be the lighthouse there, and you can help to identify and close that health gap. What was also fantastic is clear and simple self-regulation. Voluntary regulation has not worked. We need to move on from voluntary approaches. Your recommendations for upstream policy interventions are the same as ours, SNAP, we absolutely support the same set of upstream policy interventions. And it's really, really important, given the key role that oral health has, when we're doing cost-benefit analysis of policy measures, the oral health benefits must be included going forward routinely. Likewise, when we're assessing oral health policy interventions and spending, that must include the latter benefits for other NCDs and the cost savings to health systems and economies more broadly. So let's keep building that economic evidence and that investment case. Probably my very favourite part of the series is you've articulated the need for a positive vision. And that, in my advocacy experience, is absolutely essential. It is not enough to go to decision makers and policy makers saying, we're under-resourced, we need more funding, this has been neglected for too long. You have to go and tell them we already have the solutions, we know what works. We know what's working in New Zealand, we know what's working in Portugal, we know what's working in Scotland, we know what's working in parts of Africa. Take the messages for the different policy environments and show them the vision that this is going to work and that our theory of change, make them bridge that credibility gap, that the theory of change that we can promote to them and present to them is one that's going to work. Just as a final thought, I think the series is an absolute bedrock for future advocacy in this space and also for NCDs more generally. Let's emphasise that lighthouse role that the oral health community has when it comes to comorbidities and multimorbidities. Let's focus, we have a consensus, I think, that the SDG target for NCDs is far too narrowly defined, needs to go beyond the big four and mental health. That's something that we're working on and happy to work on that with you. Let's bridge that accountability gap. So we have global political commitments at the UN level for NCDs, but they're very, very rarely translated to national political action. And I would suggest that this is an area that we need to focus on as well. Bridging that accountability gap from the global level, relatively easy political promises, to national level action that follows up on that. And that's where we really need to work together going forward. Also calling out, as you've done so well in this series, the industry interference. This is a huge complex. It's not just junk food, sugar, soda, alcohol. It's advertisers, it's new media, it's old media. It's a massive complex. And we're only going to be able to tackle this if we keep working on it in a closely coordinated fashion. Thank you.
Firstly, I thought, what on earth are they doing inviting someone who works on the obesity issues here to an oral health presentation? What have we got in common? Why am I here? How come I'm a stakeholder in this fantastic production, to which I congratulate Richard and the Lancet? And of course the answer is there are lots of overlaps. There are plenty of ways in which we have common cause, not least because in fact periodontal disease and obesity are associated, that people with obesity are more likely to be suffering periodontal disease, and vice versa. People with periodontal disease seem to have a raised risk of obesity. Causation, I can't tell you which way round it goes, but what I can tell you is that if you try and treat obesity, particularly with some of the more surgical approaches like jaw clamping or stomach stapling or other forms of bariatric surgery, what you get is a patient who is desperately hungry, can't eat a lot of food, so uses soft drinks. And we've seen a number of cases where people are no doubt going to develop tooth disease because they are trying to meet their calorie needs, desperate as they are, by sucking drinks through straws, liquidized Mars bars and the rest of it. So there are overlaps, some of them extraordinary like that, and some of them more sensible. For example, both people who suffer from obesity and people with periodontal disease are likely to feel stigmatized, that there are overlaps there, that you feel shameful, you don't want to show your face. In fact, I remember Aubrey Scheim saying that what motivated him to turn from regular clinical dentistry to public health dentistry was meeting a child who didn't want to smile because he had lost teeth. Now, that sort of stigma, that sort of feeling ashamed, not being able to show your, in this case, teeth, but in the case of people suffering from obesity, you don't actually want to show yourself at all, body shamed, has a huge overlap, I think, of interest there for both of us. So maybe obesity and oral health have some commonalities. Another obvious one is the social gradient. that it's much more common to find people suffering from obesity in lower income households, at least in higher income countries. That's not necessarily the case in low income countries, and I suspect the same for oral health in low income countries, that you may find it's actually the urban middle income that's suffering most, as certainly is for obesity. And of course, there's another overlap, which is that you've more or less taken the same diagram that we had in our Lancet series to put into your Lancet series. That one on page 256. Of course, everyone does this diagram, but it's a wonderful diagram you've got. Well, we did the same when we had a Lancet series, more or less showing, from the disease outcomes through the proximal through to the distal causes, through from the direct biological up to the sort of social and commercial determinants. And I'm delighted to see that in fact, if you replace the word oral disease with obesity or even metabolic disease, you could have the same diagram. Every single word, I think, otherwise, is absolutely the same, and the commercial determinants are identical. So, yes, we share a huge amount of overlap. Except for one thing. You have a series, we've had 2 series, and if I can give you an ambition, it's to have a word with Sabina Kleinwert here from the Lancet, who helped us convene a commission, a Lancet Commission on Obesity, which we published earlier this year, the first report of the Lancet Commission, which in fact turned from a Lancet Commission on Obesity into the Lancet Commission, the global syndemic of obesity, undernutrition, and climate change. So because we found, and this is perhaps an interesting point for you too, we found it was actually, I have a few copies I'll put upstairs when we have drinks, we found it impossible to distinguish the sort of multiple causes and multiple correlated actions, the systemic actions in the food system that were causing both undernutrition and obesity, and to some extent, because agriculture is a huge contributor to climate change, all 3 had common elements. And I think we'll find actually that there are a lot of those common elements, like that diagram, are going to apply to oral health as well. And so, although I am not sure about whether you should submerge yourself into the NCD Alliance and be lost, or can coexist with the NCD Alliance as we do. We're members of the NCD Alliance, but we have a strong independent voice as well. So let me invite you to coexist with them, perhaps be members of them, but continue to have a strong and independent voice, and co-partner with groups such as ours in developing these concepts, these multiple concepts where a syndemic of correlated problems are occurring simultaneously and have common drivers. Now, our Lancet syndemic, if you like, took the issue of commercial determinants a little further and asked ourselves what we, like you, at the end of the second series, had a list of sort of challenging demands that we had for changing, doing this, that, and the other, very much like the sort of demands you have in your conclusions, in fact, for both of your papers there. But the Commission tried to go one step further, tried to talk about how do we put that into practice? What does it actually mean? Are there policies that we can advocate for that are double or even triple duty wins, so that you're winning for undernutrition and for obesity and for climate change at the same time? And we have some examples in our Lancet Commission. And in fact, I'm looking at them and I was thinking, they would apply to you as well. There are things like conflicts of interest, tackling lobbying at a high government level, because that undermines just about any of the actions that we want to see undertaken. Conflicts of interest, exposing conflicts of interest, showing how lobbying works, tackling that. Now, it seems to me that that's one of the ways that we can help, because to get the policies that we want, we're meeting inertia. We called it policy inertia. We're meeting resistance. You obviously get resistance from the commercial interests, the status quo that doesn't want to change. Sugar industry perhaps is obvious, but alcohol and tobacco are also oral health problems. You get reluctance of governments to implement regulation. There's particularly sort of anti-regulation is the sort of ideology of the era. So intervening in markets, regulating markets, quite difficult to get governments to do that, not just because they're being lobbied, but for ideological reasons too. And perhaps third, you don't get enough challenge from civil society. There isn't a very high demand to do something about obesity. And I don't think that, as we've heard earlier, there isn't a very high demand to do something about oral health. It's not a civil society issue the way plastic in the ocean or air pollution is. Oh, I have 1 minute. Okay. So let me encourage you then to think about these sort of triple wins, double wins, triple wins, or if you're going to join with us, quadruple wins, win, 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 win. Okay, another one, sustainable food-based dietary guidelines. That was one. So a food-based dietary guideline is a national recommendations, which are very valuable for helping to bring in regulations on marketing to kids and so on. If you can add sustainability to those, then you have a sort of win-win-win for the climate change people too. Human rights. You have human rights in one of your diagrams. We are proposing in our Lancet Commission thing stronger human rights, particularly a right to well-being, which brings in health, brings in rights to food, brings in children's rights and so on. We talk about next generation, so legislation for protecting the next generation. Wales has done a sort of sustainability legislation for the next generation. Very valuable to discuss how that can bring in a sort of composition of win-win-win actions there. And a framework convention where we all dream of framework conventions because tobacco was remarkably successful. I would love to see one in food systems for health, protection and promotion of health. I suspect that may not be the way the world will work at the moment, but it'd be nice if we could. Thank you.
To start, of course, I would like to thank you for inviting me, taking part of this panel. I also would like, of course, to sincerely congratulate entire Lancet editorial teams and all the authors for this very timely and so important papers. This Lancet series on oral health, I think we agree on this, it's definitely a milestone which serves the work of people and communities engaged in global health and global oral health. It also serves the work of WHO Global Oral Health Program. So the good news, of course, it's most of the authors who are been engaging in these papers are already collaborative with WHO. And some of them are part of our strong network of WHO collaborative centers. And as you may know, these collaborative centers are kind of driving force to the WHO Oral Health Program. So it's a very timely publication. And because I think the global oral health community was expecting to such strong and political commitment for a while. And because I think I wish to believe that at least a huge part of oral health community wants to work toward a more equitable health outcomes. And I think definitely it's congratulations to all of you who contribute to this. Let me also be quite clear about the fact that I'm fully in agreement with the observation made and position expressed in these two papers. And we knew that, of course, the oral health situation was serious. We knew that most of the poorest people and communities have no access or very limited access to essential oral health care. We knew that most of the children around the world are not exposed to safe and preventive oral health interventions. We knew all that, more or less, but it's definitely this Lancet series, bring a new light on the situation, and it's definitely important. So I mentioned that this publication will serve to advance the work of WHO, and it's definitely true. Why that? As you may know, the WHO Oral Health Program is implementing a 3 years roadmap, And one of the top priority of our project is to develop and launch a new global oral health report. So the plan is to finalize this publication by the end of this year and to have a launch next World Health Assembly in 2020, May 2020. So definitely this Lancet series is paving the way for this agenda. And our plan, of course, it's once we will have this publication, this new report, we hope that it will draw the attention of member states, of delegation in Geneva. As you know, it's very political, WHO and UN. And so we need this strong advocacy document. These series are definitely part of this, but we need a WHO document that definitely will create a kind of shockwave to the Ministry of Health and the member state to ensure that at the end, because this is the decision is between their hands, they can request to the Secretariat WHO to develop a global action plan or a new resolution. And I think it would be great, of course, that next year in 2020, following the launch of the global report, following this nice publication today, to have this request coming from the countries. It's our plan again. With your support, maybe we can achieve something. So the oral health situation is serious and radical reform are needed to improve the situation. But I think we could try to be a bit optimistic, and many windows are always open. But of course we have to be prepared and we have to work more closely. It's true that several people mentioned the fragmentation of oral health sectors, and I think we have to work on this to ensure that at the end we have kind of task force, working on specific technical aspects to move forward this agenda. Having said that, how to move the global oral health agenda? I think at this moment we have, Habib mentioned already this, but we have three main bridges or windows of opportunity to contribute to the global health agenda. Because I definitely think that global oral health community should and must contribute to the global health agenda. I think, well, my view is the last decades oral health sectors have been working mainly in isolation. It was quite clear with some presentation, and we maybe never really contribute concretely to this global health agenda. So there are, I think, three main entries. The first one, of course, it's NCD. It's quite clear since September 2011 that oral health, oral disease are part of the NCD family, and I think we have to build up something based on this. And the two main topics or agenda, I think, linked with NCD agenda is the first one is surveillance and indicators, because there are already, of course, framework indicators, but we have to work, as Habib mentioned, about simple indicators after decades of DMFT and CPIs were very difficult to understand if you are not in this oral health box. So we have started to work on these new indicators. And the second one, of course, concerning NCD agenda is the best buys. We need also to work on this WHO choice methodology with a group of researchers to develop a set of cost-effective intervention in oral health. I think it would be a strong contribution, and also it would be so a strong proof, for the colleagues in charge of NCDs. 1 minute? No. Okay. The second one is UHC initiative. I think it's also definitely important. It's a bit the baby of our new DG, Dr. Tedros. And we know that oral health must have more prominence with universal health coverage. But again, I want to be a bit critic. I think it's you know, it serves not a lot oral health if few months before the UN at level meeting, some organizations are claiming that we must have oral health into universal health coverage. I think we need to be prepared, we need to develop some technical guidance before, and this is it's something that we haven't achieved so far. So with UHC, we are working now on a set of UHC intervention, and again, there is a very important work to do to ensure that based on the best evidence, we will have a new package of essential oral health care, at least at primary health care level. The third bridge, it's linked with the Minamata Convention on Mercury. I think it's also a very important opportunity. If we want to think about the future of dentistry, we definitely need to think about kind of green, safe, non-invasive oral health care. There is a massive work to do with all the oral health community. We started, and we hope to get some funds from UNEP and Jeff7 to start working on this, and I think again it's quite an important one. At the end, two ideas. I think it's kind of missing pieces of the two papers. I think we have to work better and more with the young students, dental students. They are quite well organized, and they are also very interested, and they are, I think, ready to build up this kind of new identity of oral health professional. And I think we have to find more seats in all these organizations with young dentists, young students to help to move this agenda. The last point, and I think it's one of the most important actors in all this chain of oral health, is the Chief Dental Officer at Ministry of Health level. We have a fantastic network. More or less all the countries around the world have a Chief Dental Officer. It's a person dedicated to implement, develop policy, and promote oral health. And they need our help because they have no old feedback with public health. So thinking about a kind of leadership program, you know, to bring them together and to, of course, to organize exchanges between regions around the world and work with them to see how we can move this global health agenda, I think it would be great. Thank you so much.
Thanks to everyone concerned for both the series and also for this particular launch, and for inviting me to come today. Thank you. So I've been asked to talk about global health priorities, and I would argue, first of all, that oral health is a global health priority. In fact, the NCDs are causing 60% of all the deaths in the world today. And the type of communication I'm going to discuss today is really basically public health advocacy or political lobbying, because really that's what we need in this scenario. And I'll be using tobacco as an example because that's my field, but actually it is applicable to other NCD risk factors as well. So advocacy is not just publicity, although public opinion, of course, is needed to support government measures. Instead, it aims to influence public policy and resource allocation. It's directed at issues, it's directed at politicians and decision makers, not at individuals. It's directed at upstream factors which influence individual health behavior, such as taxation. It can include everything from media campaigns, public speaking, letter writing, commissioning research or polls, filing legal challenges, looking at trade treaties in particular, and lobbying political decision makers. Political lobbying usually provokes intense counter-arguments from the industries concerned. These campaigns, in fact, are often run by groups with very few resources, as the NCDA will know, and it doesn't always produce very quick outcomes. But advocacy that is directed at governments is really so important because there are some things that only governments can do. Only governments can pass legislation. Only governments can introduce a tax policy, a fiscal policy in terms of public health. And only governments can ratify and implement UN treaties, such as the FCTC, but also things like the trade treaties as well. These are really important in public health. So what influences governments in relation to policy? And I have to say, and I've worked with many different countries that range from communists to kingdoms to democracies. I've 3 times recently been to North Korea, for example, working with the government there on tobacco control. What influences them is predominantly economic. And so there is therefore a very great need to counter industry misinformation on economics. And that is that disease control will harm the economy, it will cause loss of jobs, it will affect farmers, it will affect the advertising industry and hospitality industry, or it will lead to illicit trade. But health economists all agree, such as the World Economic Forum, that the cost of prevention today on all the NCDs will far outweigh the cost if we have inaction now. In other words, a kilobyte of prevention today or a gigabyte of repair tomorrow. So I think the fundamental thing is it's not health or economics. Tobacco control and other risk factor reduction for oral health is good for the health and the wealth of nations. And that's something that we really have to get the politicians to understand. The obstacles and the opposition are many, many, many. And they are surprisingly, however, universal, no matter what kind of country that you're working in, as I've described. Opposition can include simple apathy or indifference to the issue. There's a lack of awareness of the real harm amongst many legislators. There's a reluctance to intervene with, quote, personal behavior. There's a preoccupation with other wars or health issues. There's very strong misperceived economic concerns, which I've described above. There's no understanding of the environmental consequences of control of NCDs, such as cutting down trees to cure tobacco, and the rubbish and the litter that's caused by discarding all these packaging around them. Health professions and governments around the world, and government funding, in fact, focus on curative medicine and not prevention. There's often a great lack of understanding that tax, a fiscal measure in disease prevention, and certainly in tobacco control, if you were to ask me what are the 3 most important things to do, it would be tax, it would be tax, and it would be tax. Because universally, it makes cigarettes unaffordable to children. It's as simple as that. But there's that understanding amongst ministers of finance is so often lacking. And pro-health groups in general lack the skill sets, for example, in tackling the tobacco and other industries. They don't know very much about smuggling and customs, economics, legislation, and the trade treaties. Any of you in oral health must look at these trade treaties. I do keep emphasizing that. And the commercial influences on health include, from the industries, the advertising, promotion, and sponsorship. They hijack the political and legislative process. They distort health and economic evidence. They manipulate public opinion to gain the appearance of respectability. They challenge and threaten governments under the constitution or trade threats. And they fabricate support through front groups. And those of you who think these may be rather extreme statements, these are word for word from WHO. But we already know what works, particularly in tobacco control. And we know it actually not just from our own research, but from the SCREAM test. If the industry screams, we know the measure will be effective. So what do they scream about? They scream about tax, they scream about smoke-free areas, they scream about bans on promotion and also packaging. And if they ignore a measure, then we know it's probably not going to be very effective, such as school health education or a ban on sales to minors. So in many ways, our research is done for us. So finally, how can the oral health community move ahead with the momentum gained from the Lancet coverage? How can the oral health community best utilize this opportunity? And I've basically divided it into 3 sections. Immediately, There needs to be not just the people in this room, everybody in this room, though it's a small number and everybody's on side. Even the Lancet circulation will reach thousands of like-minded people. We have to engage the media with press conferences, press releases, media coverage and social media. We have to disseminate these reports and the press releases to all governments, UN agencies, oral health organisations and practitioners globally. And we need to disseminate these reports at every conference, oral health conference, public health conference, economic conference. These reports should be in Davos. We've got to get across the idea that this is a political and a very important economic issue. I think, secondly, there seems to me to be the need to establish a global mechanism to coordinate all of this work of monitoring the health, monitoring the economics, particularly monitoring industry tactics. And this could be a very good project for a university, for example, for a PhD student to look at what is the industry doing in the same sense that in tobacco control we are. And this could be coordinated by a WHO collaborating centre. You have 2 already. Of course, involve the FDI and others. The funding, again, much thought needs to be put into that. Whether to put together a comprehensive proposal to a big philanthropic foundation. And certainly Gates and in particular Bloomberg have moved from just really looking at tobacco to looking at obesity, to looking at alcohol, to looking at other NCD risk factors. And now, of course, you've got the full endorsement of the Lancet. Funding from the dental industry, of course, has to be carefully thought out. And WHO, for example, has a firewall between itself and the tobacco industry. There needs to be some discussion about what that firewall, if any, should be in terms of both obesity and indeed oral health. And draw up a strategic advocacy plan. I'll finish with this because I've lived now in Hong Kong for 52 years, and I would like to finish with some advice from Sun Tzu's Art of War, his 5 battle strategies, 500 BC, and you can get no better advocacy plan than Sun Tzu's Art of War. 1, measure the distances. 2, estimate the expenses. 3, evaluate the forces. And that means identifying key decision makers and how they can be influenced. Identify allies, including champions. And it can be a president's wife. I had the president of Indonesia some years ago saying to me, "I think you want me to pillow talk my husband." And I said, yes, that's exactly what I would like you to do. And to identify, expose, and challenge the industries. These epidemics will never be reduced unless we challenge the vector. We wouldn't dream of trying to treat malaria without looking at the vector, which is the mosquito. And we have to look at the vector, which are these industries that are driving these epidemics. We have to become much more politically and economically aware. His 4th point was assess the possibilities and set objectives and targets. And 5, to plan for victory, formulating media advocacy objectives and particularly political lobbying. Because the NCD epidemic and oral health in particular, in fact, will never be solved in the corridors of hospitals, but indeed in the corridors of power. Thank you.
So now the floor is over to you. We have approximately half an hour. So when you would like to ask a question, we have some roaming mics. If you could just say your name and the organization or institution from where you come, and then please fire away with your questions.
Thank you. Nick Armstrong from the British Dental Association. What I'd like to know is, tobacco, we were very successful. Almost overnight, it disappeared from all sporting events being advertised, it disappeared from the TV, it was taxed. Why should sugar be such a seemingly much more difficult challenge? It seems to have all the same ingredients in all the right amounts.
Who would like to
I didn't take on the tobacco aspect. It actually wasn't overnight.
No.
I mean, most countries spend decades getting legislation in place, and as soon as they pass the legislation, they then know they have to go a step further and up the legislation to include it. But I do think the Framework Convention on Tobacco Control it was a very big impetus in making countries know what the others were doing. I mean, I remember in Cambodia once them saying to me they had no idea what was happening in their neighbouring countries. One really good thing of the Framework Convention and its reporting system is that we actually know now what's going on in every country, and there's a sort of government increase and sort of shaming of other governments, in a sense, to try and do best practices. I think that did make a bit of a jump there, but it's never an easy process. And if you look at all the other communicable diseases, I mean, it's taken 100 years and more, and some of them are not really, malaria, TB is not solved yet. So I think, you know, the reality is that we're looking at a century when we're talking about really overcoming these problems.
Thank you.
And I just want to add on the sugar industry aspect and echo the fact that it took decades to truly understand the role of the tobacco industry and to use that to implement these tobacco control measures. And I think we're only really beginning to appreciate the role of the sugary food and beverage industry in delaying any type of meaningful regulation and legislation. It took litigation to bring the tobacco industry documents to light, to help the tobacco control community to really understand the tactics of the industry. And I think that played a major role in providing a solid foundation for tobacco control measures. And we just now have launched a food industry documents library, actually, at the University of California, San Francisco, that's modeled after the Truth Tobacco Industry Documents Library. And it's a small collection, but growing, and we hope that that will begin to help us understand the impact of this industry.
Nina?
I mean, also because other health harmful commodity industries, whether it's sugar, broadly junk food, chemicals, alcohol, they've learned from what happened with the FCTC to the tobacco industry. And the tobacco industry, we've even seen this ourselves, they go, for example, to global sales and marketing conferences, JTI, BAT, and offer their advice to other industries in a similar space, perceiving similar threats, to how you avoid being cornered in the same way that we have been with the Framework Convention. And there are specialist public affairs consultancies, for example, that focus on these kind of industries that feel threatened by public health policies. So the response is coordinated across the health harmful commodity industries very closely. So for me, that's also, you know, an even stronger reason why we have to coordinate across the global health and the whole sustainable development, gender equity, child rights, human rights. The opposition is massive, and working on the EU regulation audiovisual media services directive, which is about advertising to kids, and what we were proposing was a much earlier watershed and for that to be coordinated across borders. What we learned very painfully is that body of industrial sectors is so powerful, so huge. It goes to Google, it goes to all of the social media, it goes to anybody, print media, TV, terrestrial radio networks, you name it. They have a stake to lose in this, and it is very, very well coordinated behind the scenes.
Robert?
Well, I'd just like to dispel the myth that we've won the tobacco battle. Globally, the prevalence of regular smoking is not changing. What we have done is shift the problem of tobacco from audiences like this, I absolutely guarantee that none of you smoke, to people who are socially disadvantaged and marginalised. And I'm sure that's what's going to happen with the sugar industry as well. So there are lessons from tobacco, both positive and negative. But I am pleased to say that the UK government has released a green paper which suggests that this country will be smoke-free essentially by 2030. Whether that survives your new Prime Minister, of course, is another issue.
All right, thank you very much.
Just add one small comment, which is that the narrative matters, and the narrative of individual personal choice unravelled for tobacco when you got second-hand smoking coming in as a major factor. After that, it became much easier then to start legislating in countries and even at local level. I don't think we've got to that narrative for sugar, for obesity, for tooth decay.
Thank you very much. Thank you very much for that question. Next question at the back.
Yes, hello, Peter Mossy, University of Dundee, but I'm putting this question to you as chair of the Science Information Committee of the IADR. We identified 3 priorities in the last year, the first of which is extremely urgent, or we considered it to be, and it has been mentioned by FDI in the form of benzene, and also Benoit mentioned it in WHO. It's Minamata. And I believe that it offers a unique opportunity for immediate action and for us to make a very powerful advocacy statement to governments who've demanded that we do something in the dental profession to reduce the mercury contamination. So here we have an opportunity to say all the things we're doing to control sugar, because the best way of reducing the demand for amalgam, and particularly in the developing world, will be to minimize the need for restorative materials. So we're actually advised, after the policy statement was approved in Vancouver, to start using social media, the mainstream media, podcasts, conferences, everything to start getting something out to the governments across the world that have signed up to the Minamata Convention, saying what oral health is doing. So ideas, I would love to be able to put a very strong statement to back up the policy statement that IADR have produced.
Any responses to that? Line A.
I'd just say that I would certainly endorse the use of less invasive materials within dentistry. And we know that amalgam has relied on a certain cavity size and a certain preparation. And we have a huge number of dental materials now that are adhesive, that allow less intervention. So I think the tide has got to be turning to using those materials rather than reliance on amalgam. I think also we do have to think about the sustainability of our activities within dentistry. So I think that's very important to align and to be aware of that.
Thank you. Benoit.
Yes, just to mention that this Minamata Treaty, it's true that it's a good example also to show that there are some countries, Netherlands for example, some Scandinavian countries who phased out dental amalgam for more than 15 years, and some are still using Germany, France, UK, and massively, and also most of the low and middle income countries. So yes, it's a good. There is a huge work to document all these case studies to understand how it's possible in Netherlands, why it's not possible in France, for example, and so there is a very important work to do, and as Peter mentioned, that it will definitely support more promotion, more public health policy, and of course less invasive and new alternative and things like this. So we have to work with industry in this case, because alternatives are between the end of the industry. So it's a very multi-sectoral program, and make it very interesting.
Merci. Abi.
Thank you. While I agree with all of this and the importance of the Minamata Convention, we just need to keep in mind that the majority of cavities in the world are left untreated. And people who have cavities do not get the fillings that they might get under an ideal scenario.
Okay, excellent point. There was a question at the back there, lady at the back. You have a microphone? Thank you very much.
Hi, thank you. Helen Crawley from First Steps Nutrition Trust. Really great to hear some baby food mentioned today. I think it's important not to forget that there's also free sugars in some infant milks, and that breastfeeding is protective, and we didn't hear anything about breastfeeding today. So I would certainly urge oral health colleagues to come and work with those of us in infant and young child feeding as well. My question is actually something different, which is about artificial sweeteners. So there's a sort of sense that reducing sugar is always good. And obviously, the other side of that is that many beverages in particular are going to have that swapped for artificial sweeteners. And I wondered if there was any thoughts amongst the panel of the potential impact of acidic but artificially sweetened drinks on things like tooth erosion, and whether we might be heading into other problems.
Thank you very much. Anyone like to pick that particular ball up?
I guess I can speak to that. I don't think it's something that we directly consider for this particular series. Am I correct? Yeah. But it certainly is an important topic, and the acidity of sodas in general, whether it has sweetener in it or not, is important to tooth erosion, as you mentioned. And I think the issue of artificial sweeteners is something that we need to pay closer attention to, because as you mentioned, I think as we reduce sugar consumption, we will see an increase in artificial sweetener consumption. And perhaps we don't fully appreciate the safety issues around those sweeteners. I know, at least in the US, the way that we evaluate the safety of artificial sweeteners is not a very thorough process. The FDA, the Food and Drug Administration, basically accepts the industry research without a thorough independent review. So I personally have concerns about the safety of some of these new sweeteners. But I do think it's an area we really need to be concerned about, particularly for children, as I think we'll see more artificial sweeteners going into children's foods, targeting children, and the threshold for safety in children is much lower than in adults. So you raise an important point. Thank you.
Robert.
Yes, thank you, Helen, for raising that issue. I was thinking of the analogy with tobacco. One of the ways that we're going to make progress in the tobacco epidemic is by promoting safer alternatives to smoked tobacco. For example, nicotine replacement products. And I was thinking exactly that same thought around sugary drinks. Sure, I'm sure there are unanswered questions, but if we can agree that current evidence, artificially sweetened drinks are safer than sugary drinks, why don't we promote that as an intermediate step forward?
Thank you very much. There was a question over there.
Hello, Vahid Rabaghi from University of Birmingham. We know that dentists are the only dental care providers internationally, particularly in developing countries. What do you think of expanding the scope of practice of other dental care professionals, such as dental hygienists, to address the access problem? Thank you.
Sorry, Did you say developing? Sorry, I didn't
expanding the scope of practice of other dental care professionals, such as dental hygienists, to address the access problem in developing countries.
Absolutely. I suppose if we were starting afresh and designing a healthcare workforce for the needs that are out there, we mightn't have the models that we have here. And actually what we have, I suppose, have been around for many, many years, and they addressed a problem when there was high caries rates in developed countries and in high-income countries. I think there is something really to be said about expanding the scope of practice and rethinking our oral health workforce, because in many areas, and he's far more expert in this area than I would be, in many areas there's no access to any dental care, and we really need to harness using allied health workers to provide some basic dental treatment. So I think we have to perhaps reimagine what we do with workforce.
Anybody else who wants to have it? Do you want to? Okay. Thank you very much. There was a question down here.
I had an additional comment on the sugar sweeteners and the artificial sugar sweeteners. In the Netherlands, there has been an agreement on a prevention, a governmental enforced 3 targets. It's sugars, it's tobacco, and overweight. Now, remarkably, the sugar industry was allowed at a discussion table. The tobacco industry wasn't. I rallied at a level late in the process. And I studied and I saw the turnover and the production of artificial sweetened drinks increased tremendously over the last decade. with a stable turnover on the normally sugared added sugars. At the same time, the chemists in ACTA, from Amsterdam, I'm from Amsterdam, ACTA, were very worried about the effects of the artificial sweeteners in erosion terms, particularly for the younger. So there's an immediate threat, I think. We say that Max Verstappen, he's promoted, he's driving Formula One and is sponsored by a firm that produces these drinks. And he wins the rally over the tooth of the children, I think.
Thank you very much for that observation. So we have a question here, then I'll come. Again, if you could say your name and where you're coming from.
Hi, I'm Paula Vassallo from Malta, and I also represent the European Association of Dental Public Health. I have maybe 3 points I'd like to make. One, I'd like to see also the role of interprofessional education in the sense of also the training of the future workforce in having a more global knowledge on NCDs in general, because I think that is an important point that we need to address, and also with a focus on prevention. Another question I'd like to ask you, Judith, you mentioned also that very much health is very much politics, as we know, and that we have to focus on the economics. How can we do it sometimes in a 5-year term? Because we know that normally politicians would have a 5-year term and they want to see the economics in a short-term period. And my other point I'd like to also bring upon is that there are lots of organizations, I'm aware, who are advocating for our health. And as somebody mentioned previously, and Benoit did, we're all working in silos. How can we get these groups to get more powerful, have a stronger voice, and to advocate for better oral health with the non-converted people?
I think it's critically important. There's a lot of health economic data already available, but I think it's critically important to keep presenting to the politicians just how these diseases are draining the economy. And as I said, that control is good for health and wealth. We were faced in Hong Kong when we decided to ban in 2007 smoking in virtually all indoor places. And the tobacco industry incorporated, they got KPMG, who do many studies for the tobacco industry, to make the most awful predictions about thousands out of jobs and millions lost to the economy. And what we did there was very simple, quick and ready. We asked our tax people, what are the tax returns of the bars and restaurants the month before the ban and 2 years later? So instead of being this economic catastrophe, it had gone up 32%. I mean, unbelievable. So, I mean, there are little quick options that you can sometimes find to look at economics, and that's been very worthwhile. There's been studies, for example, in China done by Virginia Lee from California, where she got about 500 farming families to switch farming tobacco to other crops, not roads and things, but actually crops. And again, over that 4-year period, she found the income of the farmers had gone up from between 20 to 110% in that 4-year period. We have got to show that these measures don't harm the economy, they don't harm the restaurants, they don't harm the farmers, because that's what governments are, I think, justifiably anxious about, particularly when the tobacco industry and I guess the other industries are bombarding them with how everything from the advertising industry will really suffer if you do as much as raise the tax by 10%. So I think in general every country should have some kind of national assessment of the economic risk of the problem, whether it's oral health or tobacco, because ministers of health even listen to it, never mind the whole of government, and legislators in particular. That's what they really, nobody really now argues, except I think the deputy president in the US. Nobody argues that tobacco is not harmful to health. It's a given. And, I think it's emergingly so the food industry. The whole debate is going to shift to the economic and political arena in order to actually get things done and overcome these obstacles.
Thanks, Judith. Anybody else would like to comment? Nina?
Just very briefly, I think it's essential as well to present to policymakers just how much business as usual already costs. and how much more it's going to cost in a short-term perspective as well. And then, as I was saying before, show them that the answers are there, that other countries have trialled it. For example, show them what's happened in comparable economic situations in their neighbouring countries, for example. And I think with things like the sugar-sweetened beverage tax, there's about 60 countries that have these now. So we're having sort of a snowball effect. There's going to be a positive spillover as that economic evidence comes forward. And not just the economic evidence, it's hearts and minds and pockets. So as Judith was saying before.
Habib, you wanted to make a comment?
Just a quick comment on what Judith said, because this economic argument that is so compelling to policymakers, to decision makers, echoes very well with the most recent drive by WHO to encourage investment case modeling on a country level. And toolkits and guidelines have been released, and that is an area where we can actually really advance in oral health as well. We know very little about this. We have a few ideas, and there are some work groups working on it, including at NYU and in the Netherlands. But this is something where we really need to come together and build a compelling investment case. Going back to the original idea that Robert presented, the Schiffman framework on how to analyze political power of an idea and how you can form alliances, how to really bring different organizations together, align them along a common agenda. We did a study in 2012 where we looked at the global oral health sector, and we used exactly the Schiffman framework, and subsequently we analyzed the situation in India and in Italy and through the similar Schiffman framework lens. And the finding really is that most organizations have their own reasons for being, and even though some of them may put up front that the betterment of oral health is their main reason for being, in fact it is not. They have other reasons for being and other drivers for their agendas, which is of course then difficult to find common ground and to bring them together around a cause.
Okay, thank you very much. I'm going to move on to somebody else.
Newell Johnson, Griffith University, Queensland. 2 questions, if I may, and Habib has just touched on the first. To what extent does the panel in the room agree with Professor Beaglehole that we need a new initiative and we need to go it alone, which is not, of course, mutually exclusive with working through existing organizations? But I found that very challenging, and I'd like to know what the rest of you think. And my second question has again been partly answered. How do we really engage politicians? Because I absolutely identify with Judith. They make the decisions, they make the legislation, they make the taxes, they make the advertising bans. And I was recently at an oral cancer meeting in Sri Lanka, and in the hotel room in the middle of the night in the final of the World Cricket Cup, I stayed up till 1 o'clock in the morning watching that for the non-British or Commonwealth people. You don't know what I'm talking about, but cricket matters. And of course it was an amazing, exciting match. But what drove me mad was that between every over, there was the same advertisement for gutka, which is an areca nut containing carcinogenic product, the major cause, along with tobacco, of oral cancer in that part of the world, and Marco's given us some data. In between every over, and that was Star Television beamed from India into Sri Lanka. So it's only politicians who can shut that down.
Thank you, Newell. Responses? Who wants to...
So Rob, you've got to sell your idea.
Well, I haven't heard any opposition. You are challenged. I think it's self-evident. You need to get your house in order. You need to make your case. You need to have your stories. I'm much more interested now in stories than I am in economic cases for investment. In my view, and from the New Zealand experience, politicians are influenced. They used to be influenced by letters. If you wrote 6 letters to the New Zealand politicians, the Prime Minister, handwritten in 1960, you could change policy. Now it's a bit more complex, but they do are moved by stories and personal engagement, and they trust their advisors, not all of whom are within government. But for me, the progress in global public health is based on very clear, simple priorities with a very explicit message and a powerful network. But I'm happy to be challenged, of course.
Thank you, Robert. And Nina?
I would just say we need all the advocacy forces that we can mobilise across the NCD case. I don't think what Robert's proposing is mutually exclusive with joining different networks, whether that's on NCDs or planetary health or the SDG agenda more broadly. I mean, looking at the opposition that we have, you know, we've got a mountain to move. And I think the more people we can bring to our cause and get involved in advocacy, I mean, you mentioned New Zealand politicians, in the European Parliament it still works like that. I've met MEPs who say, oh, I've had 2 letters on this, tell me what you want. I mean, they're very unloved at some levels of governance. So, you know, let's mobilise and see what we can do. But I would say it's absolutely vital to coordinate and not cannibalise each other's messages. I mean, we've just had, there was a bit of a back and forth around the Cancer Research UK's obesity work, and it's absolutely vital that we talk to each other, we communicate with each other, and we don't allow the industry, who are very much on top of this, to divide and conquer. We have to make sure that we're echoing the same messages. And I would maybe propose that groups like ours can help to facilitate these kind of debates and, you know, basically having a solutions focus, making sure that we hit the media with a solutions focus and that positive vision.
We're coming towards the end of this discussion session. I'd like to ask one of the dentists on the panel how they respond to Newell's challenge and indeed to Robert's challenge to that the oral health community take the lead in this.
I'll say something. That's one of the dentists. I agree. I think that we have a lot of opportunity to strengthen our own voice. And I'll give you one example, which is that we are still debating whether it's the frequency of sugars consumption that's more important than the amount of sugars consumption as it relates to tooth decay. And that often becomes an excuse not to take policy action because we focus more on frequency than amount. So I think if we could come to some agreement within our own profession, that's one area where we could improve and speak with one voice to support our advocacy.
All right, last conversation to have you.
Just on this aspect of engaging with decision makers, this is not a simplistic one-way process where you go to someone who has the label decision maker and you put the evidence on the table and then you expect reaction or action. It doesn't work like this. This is a long-term engagement process. It's a long-term process of understanding the system. Every decision maker is there for a certain term, but there's technical staff behind that supports and builds the administration. So it's good to engage on a long-term level and also on a personal level, because those are not amorphous and anonymous organizations or institutions. These are individuals. And most of the time you find people with a listening ear, with an open mindset to hear new ideas. But you have to engage in the right way and with the right expectations.
So thank you very much on that. Okay, one last comment for...
Yeah, I think that one aspect that we haven't touched today is that we are talking about to put the mouth back into the bodies, but we need to talk about to put the sub-dental health system into the national health systems as well. Mm-hmm. If you look at the current typologies of health systems, it's very difficult to find that the sub-dental health system follows the same structure. For example, in Canada or even in Australia, we have a universal health system, general speaking, but dental care is not in there. I think that this is an opportunity to promote that. To put the mouth into the bodies, you need to put the dental health system into health systems as well.
Okay, thank you very much, Marco, and thank you very much to the panel for... We're really privileged to have a wonderful part of the dental community who's been a leader for so many years. Let me introduce Lois Cohen from the National Institutes of Health in the USA.
Well, thank you very much, Paul, and thank you for the honor of inviting me to this wonderful event. I want to extend the gratitude of the National Institutes of Health, and particularly the National Institute of Dental and Craniofacial Research, where I worked most of my career. But today I am not speaking officially. As many of you know, I retired in 2006 and assumed another role as the Paul Rogers Ambassador for Global Health Research, and also a consultant back to NIH, but also to WHO, to academic institutions and others. So I want to make a few comments as back to my own identity and where I come from and have come from in the dental space since 1964. I'm a research sociologist. I'm not a dentist. A lot of people don't know that. But I have been recruited to this wonderful field because there's so many interesting questions to ask that are not answerable, perhaps, by people trained as dentists. And one of the first things I was asked to do was to look at why dentists don't look at the soft oral tissue, why they didn't examine for oral cancer. And we looked at the sociology of the profession, that they were, at that time in the 60s, looking at hard tissue. Now, today, they are looking at soft tissue as well. So we have evolved. But I'm going to skip a few steps from looking at water fluoridation, which is the US national policy, major policy for the prevention of dental caries, to the period of time of then President Richard Nixon. Now you wonder why I bring that up. He was one of the first people in the States presidents to bring up national health insurance and universal health coverage for our people. We still don't have it, but it was because of him that the oral health part of the US government said, what are we going to propose? Here the administration is going to make a proposal. Ted Kennedy has a proposal. This one has a proposal, that one, but we have no proposal for oral health. And so we had no evidence either, because this was a system of fee-for-service private practice dentistry. And so we had no models other than that to propose for national health insurance. So what did we do? It was during the Cold War, and we went to WHO because WHO was a neutral body for governments to interact. It was a platform where we can talk to each other. And lo and behold, the chief of oral health was a Russian. But our chief dental officer, some of you know John Green, of the Green and Vermilion Index, was our deputy assistant secretary for health, and our chief dental officer went to the Russian, Dr. Vladimir Rutko, and said, we have a problem. Can you help us? And they came to an understanding across that Cold War line that we could work together. Because what we could do is bring a group of nations together who are interested in that problem and talk about a common research protocol where we could gain the information we needed on consumers, providers, and administrative structures on systems where they had at least 20 years history of having dentistry integrated into the oral health systems. And that was the birth of the WHO International Collaborative Study of Oral Health Care Systems involving 10 industrialized countries. It was followed a decade later by ICS-2. We called the first one ICS-1, ICS-2. David Barnes, oral epidemiologist at WHO, was assigned by Vladimir Rutko to be the co-PI. And I, a research sociologist, was assigned by the US government to be the co-PI. And we brought together 10 nations. We actually involved more, but 10 were officially involved in that collaborative protocol. So with that history, I'm going to fast forward, okay? Not go through all those steps. Today we have much more precise information. We have, of course, the information that came out of looking at the structural characteristics of nationally developed oral health care systems and using a metric of health outcomes of how well those service systems met population oral health needs. It was a ratio, a metric that was service over need. That was a metric, the metric by which we made comparative statements. So we know that, and we have the global burden of disease, and we have a lot more precise information about utilization and the nature of not only hard tissue diseases and oral cancer, but salivary gland disorders, cleft lip and palate, other diseases, that ectodermal dysplasia, NOMA. We have a lot more information, which leads me to saying maybe it's time now that we do two things. One has been stated already, that we have a national look within our own countries, not only to see, because countries differ from one another. They are not all the same. You can have an international look and have strategies that are international, but you also have to have national specific strategies to address specific oral health needs and the existing structures in that environment and different decision makers. It's not always the Ministry of Health. It's not always the Chief Dental Officer. It could be the Chief Financial Officer. It could be the Parliament or the congressional committees that put, and the politics of the time in the states, whether both House of Representatives and the Senate are of the same party, that can influence the president. So all of that changes. It not only is structurally different, but it changes over time because you always have elections, and that changes the dynamic as well. So I'm proposing another national strategic assessment. We used to call them situation analyses. Each country does their own situation analyses, not only from the oral health perspective, but the general health perspective, to look at oral systemic connections, comorbidity, as was raised here. And then my thought is to have, again, some kind of global commission, panel on a neutral platform that isn't owned by any one set of actors, a neutral platform that can talk about the international trade issues, the issues, international health regulation issues, the Minamata kinds of things that are cross-national, that go across each country and may have similarities and may not. But I think you need both things to operate again. And another thing that occurs to me has to do with ethical public-private partnerships. And all societies are not the same. In a capitalist society, you have strong drivers of positive and negative change in the private sector. They have both positive and negative aspects. And I remember parts of the discussions for 10 years. There was a Foods, Nutrition, and Oral Health Consortium led by the American Dental Association that did look at non-karyogenic sugar substitutes. That has to be looked at again, as many people have said, because times have changed. We also didn't look at tooth erosion particularly. So there are ethical public-private partnership arrangements that can deal with conflict of interest. And maybe conflict of interest rules weren't as strict as they are today, and there's always room for improvement. But I'm a person, I guess, maybe that's the sociologist in me, that I see collaboration as the way forward, not polarization. We've had a lot of polarization lately. I'd like to see more collaborative action. And finally, along the same lines of collaboration, I'd love to see a global research agenda. Of course, I worked my whole career in a research environment, a research sponsor environment, being that NIH is probably the world's largest supporter of biomedical and behavioral research. We had a global oral health research agenda. We started in 1989 with WHO when David Barnes was heading the oral health unit then. And they helped us. They actually assigned Phil Holloway. They contracted with him from the UK to come and help us. And we had a large array of global actor researchers come and advise us and set a research agenda. It was very long. And the research agenda was driven by answering questions that require international collaboration in order to answer, that we cannot answer solely in one country. Things like alternative restorative materials was on that. Closing health disparities was on that. NOMA was on that. A disease many people have not heard about, but is still there in West Africa, was in the concentration camps of Europe, was even suspected in Haiti at the earthquake, right after the earthquake, and drove PAHO to ask for oral health leadership in this area. So there are many questions. What is the optimal level of fluoride for all sources was on that research agenda. Cleft lip and palate. Dr. Massey was very much involved in that too. There are many issues. So I think we need a new global oral health research agenda with the contemporary questions. And I think we shouldn't forget that because our future depends on solid evidence. And health policy depends at least on the evidence, the political and economic will, has been mentioned many times, but also social will. And we've heard about that, and advocacy. Those three things lead to changes in health policy. But that's my 2 cents from a research sociologist.
Try to be super quick. A big thank you to Jocelyn and to Richard for bringing together this tremendous team of authors, bringing all you together for the birth of this new movement on oral health. I'm really privileged to be here. And it's very paradoxical that we're meeting in Bentham House, because I think we can all agree that the global health community has not brought the greatest happiness to the greatest number when we think through the lens of oral health. Now, when we give a platform for a neglected domain of the global health community to come and speak about why they should be given more attention, they usually regale the audience with wonderful examples of their shining excellence, the fantastical contributions that they make, their indispensability to the world of health, and their unjust neglect. And while you have done all of that in many ways, rarely do we ever hear a cry of anguish, which you have issued today about the urgent crisis that faces your own community. That is remarkable. In my experience, it's unprecedented. It's courageous. And I hope it's not a mistake. And I say that because the danger of exposing yourself to that kind of self-criticism is that those very people with power might say, we have to wait until they get their house in order before we embrace them in that political discussion, dialogue. But that is why what you face is this immense opportunity. Because the failures that you have described are not your failures alone. I work across all domains of global health. The NCD movement has, for all practical purposes, ignored oral health. The global child health movement, for all practical purposes, has ignored oral health. Much has been talked of universal health coverage. I'll have a word to say about that in a moment. Oral health, not central to the discussions at all. Human resources for health, nutrition, every domain I can think of in global health has not adopted oral health as a foundational dimension of its work. There is a pervasive, a systemic failure across the entire system, so you're in good company. So this extraordinary opportunity means that you need to keep your messages simple. What you don't want is a long laundry list of asks. Universal health coverage is a great way in, but be aware it's everybody's great way in. The struggle for universal health coverage has become a battleground for many dimensions within global health. And that means that you have to be organized, but you have to be disruptive, you have to be difficult, you have to be awkward. You're way too polite as a community. And you need to learn the lessons of the AIDS movement, who were not polite. They were angry. You need to sharpen up your anger, tell stories, mobilize civil society, make the evidence work, put it to use. You've been presented with a false dichotomy of a global oral health movement versus activism within the broader NCD movement. You need to do both. You've got a great target, a villain, sugar. That's great. So what are you going to do about it? What are you going to do to mobilize action against the sugar industry? It's a very, very powerful trope to bring together your fragmented, isolated, and hitherto weak community to make an impact in that area. The scope of the reform for your own discipline, though, is huge. Education, training, services, prevention, public health, research, leadership, governance, public v. private, vision, philosophy, the very meaning of oral health are all dissected in these two papers and in the discussion this afternoon. So where are you going to start? What's your plan? That I haven't heard yet. We've got these three opportunities of universal health coverage, sugar, and the need for your plan. But we simply can't walk out of this room, go up the stairs to the reception, without thinking about what that plan has to be. There has to be an afterlife to this series. There has to be something that follows it. So here's our pledge. We need to think of today as a beginning, not an end. If we're really going to create this movement around oral health, then let's create this coalition. The best picture in this booklet is the picture of all the logos of the participating academic institutions. Let's add partners to this page. Let's build that movement through partnership and a coalition. We will help you build that platform. It's been suggested there should be a commission. We have lots of commissions at the Lancet. If you want to work with us to build a platform, a commission, to think about how we take the messages of this series forward and build that movement, we're there with you, at your side, fighting this struggle. So let's start. Thanks to all of you. Thanks to everybody who's enabled us to be here in this wonderful room. It's the beginning. Let's fight!
Thank you very, very, very much for that very inspirational and rallying call. And I think we've got the message. We need to move from discussion, we need to move into action. We need to think of collaboration, all the things we've mentioned today, we need to move forward. And the best bit of news we've got is we want to work with the Lancet, with you all, to move this forward, because alone we can't do it. So I think that really is the brilliant end message for us. So thank you very, very much indeed, Richard. I just want to do some very boring but important thank yous as well. We've heard a lot from many speakers, but I'd like to particularly thank our co-authors for the presentations. We've had very interesting co-author presentations. I would like to thank the expert stakeholder panel for their contributions, the varied, some challenging, but all very interesting and important points. I would yet again, want to thank the Lancet team, and in particular, Jocelyn Clark in the front row here, because she really has been inspirational to work with. She's driven us, she's supported us, she's given that enthusiasm, and that really is a once-in-a-lifetime opportunity for us. So Jocelyn and her team, thank you again. I also want to thank the UCL team that have put this together. So Louise, Renato, Michelle, Carolina, Anita, Nicola, Mohammed, Zainab, all my UCL colleagues have made this all work. So thank you, all of you, for your help. Thank you all as the audience for your participation, for your attendance on this very hot, stuffy day. But it's been a very, very important afternoon. So thank you all very much.